Stephen, welcome to London.
Thank you.
I think we should probably start with you telling us a little bit about the role, your particular role, and the work of your centre.
Yes, I'm the Deputy Director of the McGowan Institute for Regenerative Medicine at the University of Pittsburgh. And the McGowan Institute is a wonderful place to practice regenerative medicine because it's a highly interdisciplinary institute where lots of disciplines are co-localized. In other words, we basically all live together, which makes working together quite easy.
And how long have you been Deputy Director?
I've been at Pittsburgh for 15 years and serving in that role as Deputy Director. It's a center that has about 250 faculty as part of it. That's a little misleading. There's about 30 faculty who do what I do. We wake up in the morning thinking about regenerative medicine, go to sleep at night thinking about it. Another 100 or so who reside in their more traditional departments but are very interested in regenerative medicine, and then the rest are primarily clinicians who are also interested in it, and they're the arm that actually executes the clinical translation of the science that we do.
So you obviously didn't start out as a regenerative medicine expert. How did you get into the field in the first place?
You know, that's an interesting question because I started doing what I'm doing in the mid-1980s, and it just so happened that it turned out to be what became tissue engineering and regenerative medicine. The term tissue engineering was coined in 1988, actually by a biomedical engineer, and then it transformed to regenerative medicine with the advent of stem cell biology around 2000. But during that time, I happened to be interested in regrowing body parts. I'm a physician also. I practiced medicine for 16 years. So actually it grew up around me. And not certainly with me at the center, but it grew up, and I found that it was a home in which I felt very comfortable, and other people like me.
Having been in the field for a number of years, do you agree with the feeling in this meeting today that we're really reaching a sea change, a step change in the type of therapies which are going to be available? I
do, and having been in it for this long, one advantage is you see the ups and downs. In the 1990s, there was a tremendous amount of enthusiasm around what was called tissue engineering at that time. A lot of money was poured into various companies like Organogenesis and Advanced Tissue Sciences. And then a combination of things happened around the early 2000s where there was a failure to deliver on some of the promises of the 1990s and also an economic downturn. And so it really took a big dip. And then during the first decade of 2000, with stem cell biology playing a larger part and us understanding the things that worked and didn't work and the value of interdisciplinary approaches, it's gradually increased. And in the past 5 to 6 years, the clinical translation in disciplines body systems from the skin to the central nervous system has been remarkable. We're definitely in an era now where we're going to see patients benefiting on a much wider scale.
And if we're going to realize that potential, what do you think are the real outstanding challenges that are still to be solved?
Well, the challenges are probably not what you think. I don't think the major challenges right now are scientific, to be quite honest, because we're starting to understand the value in using the body as a bioreactor, for example, rather than doing things outside the body. But the regulatory challenges, when you make more than incremental advancements in a particular field, become quite burdensome. And reimbursement issues, as these are very practical issues that are actually one of the biggest barriers to clinical translation right now. And there's one other, and that's education of the caregivers. If you have a minute, I'll give you an example of this. If you take a problem for which there is, for decades, there's been no advancements or very little advancements, like say, the treatment of stroke. Since the 1980s, there's been almost nothing that's made a significant change other than better rehabilitation. So in regenerative medicine, there's the very real possibility now that stem cells identified within the central nervous system, combined with appropriate biologic scaffold materials, can actually regrow new brain tissue. And of course, it would have to be retrained. Well, that is so far away from the thinking of physicians who've been trained the same way for forever, that for one thing, they have a hard time believing it. Secondly, it's something more than just delivering a pill. It involves a combination of therapies, different types of changes that go against the practice of medicine sometimes, reimbursement challenges, lawyers waiting to sue you if something goes wrong. When all of these things come together, it becomes difficult for the pioneers to say, I'm going to take a chance, I'm going to do this because I want to make a difference in the way patients are treated. So the science can be there, but if all of those other things aren't handled in appropriate ways, it's going to delay the patients receiving that type of care.
All right. But I presume you're not saying that all the science is done and dusted. There's still some challenges there in the basic science?
Oh, sure. There's always going to be challenges in the science, but we've made significant advancements in the past decade in particular. The challenges in the science are actually what's the fun part.
And where do you see the sector going in the next 5 to 10 years if we get those challenges, those barriers taken away? What's the limit to this technology?
Well, I don't know that we do know the limit, or not. I'm not sure we know it, which raises an ethical question. Let's say, for example, we can regrow an entire limb or part of the central nervous system or even part of the brain, and we could replace all of these body parts. How far do we really want to take that? I personally, I would rather think of it as quality rather than quantity of life. I'm not sure many people really want to live to be 120, but if you could live 80 or 90 years and be robust and have all of your faculties, including your mental faculties, before you die, I think that would be a real positive outcome to regenerative medicine.
So you're giving a keynote speech later today. Without spoiling the content of that, could you give us an outline of the kind of things that you'll be covering in that?
Sure. What I was going to talk about was basically a history, not just starting in 1990, but much before that, and what's been done in some of the major advancements over the years, and then focus upon how concentrated these advancements have been in the past 15 to 20 years, and then give actually an example of clinical translation of an entirely different approach to a significant medical problem. And during the course of that, outline what the challenges are. I think we are on the precipice of making a difference. It's not going to be easy. I don't mean to imply that at all, but it's quite exciting.
And do you think we need to educate patients to be realistic about the next therapies that are coming through, or? Well,
yes, that's always the case, though. Actually, it's the same case right now. But it certainly with the access to the internet and the information that's available, patients come into the office now, oftentimes more educated than the physician is with their particular problem, and sometimes with unrealistic expectations. So, yeah, you're right. Educating patients is going to be just as important as educating physicians. I think physicians tend to be a little bit more stubborn, though, because we're pretty well entrenched in our ways, and we've all been trained certain ways. It's a challenge.
And do you think there's a time for a new clinical specialty in, say, advanced therapies? So one of the things people have talked about is educating individual organ system clinicians in different advanced therapies, but do you think there should be just a cadre of advanced therapy clinicians?
Well, that's an interesting perspective. I think that I'm not sure it would be one new discipline, but as both of us have seen in our lifetime, we've become more and more specialized, in each discipline. The cardiologist, you have the electrophysiologists, you've got the cardiac surgeons, you've got the people that treat medicine and so forth from a medical standpoint. However, a regenerative medicine approach within the field of cardiology is likely going to involve interventional methods, stem cell biology, biologic materials that enhance their innate regenerative capacity, an immunologic approach. So I think there's going to need to be I think it could be a specialty of someone who is responsible for understanding the combination of those different disciplines toward a positive outcome, because certainly none of those specialties in themselves are trained that way.
And you've been coming to these conferences for a while. What is there anything specific that you think you're going to get out of the conference this year?
Well, one thing I was glad to see was the rather robust emphasis on immunology. When I went to school, the immune system was what protected you against infectious disease and things. We now know that the immune system is absolutely critical for normal fetal development. It's essential for species that do regenerate, like a newt or a salamander, to regenerate. And so our understanding of how the immune system is important in regenerative medicine has just grown by leaps and bounds. So I think that's if you had to ask me which particular aspect of the meeting was most exciting, to me it's that aspect.
And do you think that will then determine this debate between autologous and allogeneic products?
Well, it's certainly going to contribute to it. There's a fundamental difference between autologous and anything else, allogeneic, xenogenic, whatever, and that is the body reacts to anything that's not self. It even reacts to self if you have to take it out and put it back. If you have to immunosuppress or somehow immunomodify a patient in order to receive a therapy, I don't see how you don't create problems. That you create another set of problems. Sometimes they're manageable. Most of the time, they're not. Not forever. So, my particular preference is that we understand how to use our body's own resources and end up with autologous types of therapy. Now that we can certainly do that with stem cells, we can do that with modulating the immune system in a positive way. That I think is a really interesting debate. It's been going on for quite some time, and there are very strong opinions about it.
And where do you sit on that?
I'm on the autologous side. Whatever we can do to make our body do what it did as a fetus. We can grow a whole human being in 9 months,
yes.
Right? So the information's there. So what does it take for us to figure out how to regrow a finger or a liver or a heart? It sounds like it might be less complicated, but in fact it's more complicated, right? But it's fun. It's fun figuring it out.
Well, it sounds like it's a very exciting time in the field.
Oh, it is. I tell people all the time, I absolutely love my job.
And perhaps one last question around the advice for someone at the start of their career. Where should they go? What field should they enter?
It's when kids walk into my office and say they think they're interested in it, they come from engineering, they come from biology, they come as pre-med students, and none of those mechanisms of training cover the field of regenerative medicine. The only way that you can really dive into this field is to open up to interdisciplinary approaches, and that's quite honestly, there's very few places in the world where a student can go and be exposed to the breadth of all of the different applications and not get stuck in one particular path and have blinders on, about whether it's a stem cell or a scaffold or something else. So it takes work. We have not made it easy for people to become good at regenerative medicine. But we're trying, I think the recognition of how important it is and the potential value is going to make the education system respond in a way that's going to provide us with the scientists of the next generation.
Thank you very much.
Oh, you're welcome, Ian. Thank you.